Editor of the Insider. Thanks so much for joining us today as we take a look at what to expect from next year's legislative session. For those of you who aren't familiar with the Insider, it's a little unusual for us to invite the public to one of our policy events. Normally we get to do those in person back in normal times, but these of course are unusual times, and you're seeing many other news organizations work to open up their healthcare coverage to everyone who might be interested in what we're doing. Today's event is made possible thanks to sponsorship from the North Carolina Healthcare Association. We'll hear from them in a short video now, and then I'll be right back to introduce our panelists.
Hey, this is Steve Lawler with the North Carolina Healthcare Association, and I want to welcome you to the Insider 2021 Policy Preview on Healthcare. It's an exciting time in our state. It's an important time in healthcare, and I can't think of a better way to engage by having these kind of conversations. So these are unprecedented times. These are times where everyone plays a role, from our elected officials down to every member of our community. So as we think about what's going on throughout our state and what's going on with the pandemic, there's certainly things that our elected officials can do to help support hospitals and health systems. So first, it's work on bipartisan efforts to develop policy and/or support packages that make it possible for our healthcare heroes to take care of their patients and their communities. An example of this was the $25 million targeted legislation that allowed the North Carolina Healthcare Foundation to purchase PPE for membership throughout the state. And that has helped shore up our supplies as we take care of patients and take care of community. Other things they can do is to make it easy for hospitals and health systems to flex and to have the flexibility to expand or to add new staff to be able to take care of patients, families, and communities. We also believe that expanding coverage for every North Carolinian also an important thing that a bipartisan effort can yield. One of the other things that is really exciting that the association is taking on is we're working with our membership to think about caring for our community as our patient. We started this work by issuing a statement on equity, that really kind of put out there that any kind of racism or injustice or inequity or barriers that marginalize our neighbors and other North Carolinians is in fact a public health crisis. And we should be looking for every means possible to create a more equitable society so that each and every North Carolinian has the opportunity to reach their full health potential. And when we do that, everyone benefits. We have a healthier state, we have a healthier workforce, which means folks are at work. We have a healthcare system that doesn't require the kind of subsidy and cross-subsidy that we have now, where those of us who are blessed to have insurance help participate in covering those that don't. Again, thank you for joining us on the Insider 2021 Policy Preview on Healthcare. It's a great start for a conversation. It's a great start to work together, and it's a great start to roll up our sleeves and do everything we can to make North Carolina a better place for all. Hey, this is Steve Lawler with the North Carolina Healthcare Association, and I want to welcome.
Thank you, Steve. I wanted to hear from you again on that, but I think we were fixed with a technical difficulty. So let's go ahead and meet our panel for the discussion. Senator Joyce Kravick is a Republican from Forsyth County. She chairs the Senate Healthcare Committee and the Health and Human Services Appropriation Committee. Outside of politics, she owns a real estate development company. Representative Gail Adcock is a Democrat from Wake County and a member of the House Health Committee. She's a nurse practitioner who until recently served as the Chief Health Officer for SAS Institute. Sue Ann Forrest is the Director of Legislative and Political Action at the North Carolina Medical Society, where she's worked since 2016. The Medical Society, if you're not familiar, represents thousands of doctors across the state. And last but not least, Tom Fetzer is a lobbyist with Fetzer Strategic Partners, where his clients include some of the state's largest hospitals and insurance companies. He's also a former Raleigh mayor and a former member of the UNC Board of Governors. Thanks all of you for joining us this afternoon. We'll go ahead and get started with the topic that, of course, is on everybody's mind these days, COVID-19. The current pandemic is going to cast a big shadow, I think, on next year's legislative session. So what actions, both in terms of policy and in terms of funding, do lawmakers need to take to address the impacts of COVID-19? And for that, let's start with Senator Kravick.
Thank you, Colin. Thank you for having us. This is challenging times. There's no questions about that. We had some great policy initiatives that came along with the COVID packages in our last session. And we hear that we're going to get some more COVID funding from the federal government. So if that happens, that will be a real help to deliver the care that we need here in North Carolina. And as we said, these are challenging times, and some of the rules have just had to go out the window, because first and foremost, the legislature is committed to improving access to care in North Carolina, particularly our rural communities. And we've been laser focused on that for the last few sessions, and we're going to continue to do that. Even with the challenges that we're facing, we're going to continue to move to improve access to those rural areas and to improve access to care for everyone. And I think we've made some really good steps in the right direction, and I think we'll continue to do that in the legislature.
All right, thanks. We'll go next to Representative Adcock. Your thoughts on COVID-19 response and what needs to happen come January?
Well, I'd like to see a continuation of the great bipartisanship that was shown in the 4 COVID-19 work groups that Speaker Moore established in my 6 years in the General Assembly. I think it was the finest example of the two parties pulling together to do what was right for our state. In particular, increasing the amount of testing available to the most vulnerable citizens, to removing barriers to providers who are trying to actually be there for their communities by waiving some requirements that in normal times, we would certainly enforce, but during the time of a pandemic, when it's really an emergency, to realize that it's more important to have the time, the bandwidth, and the complete focus on the care of the patient versus some paperwork. I think those were some of our finest hours.
Thanks. To go back to Senator Krovic on this, I know we're sort of hoping to see federal stimulus money come in, and the legislature being able to allocate some of that. Given that the state government does have a decent surplus going into the new year, do you see any need, any advantage to doing any sort of state-based recovery package related to COVID?
We haven't really had a chance to discuss all of that at this time. So, we'll be up to my colleagues, and, everyone will be contributing into that conversation. So I'm not certain what steps will be taken. I know we have a lot of work to do. We've got a lot of things on our plate. We've got a lot of good policy ideas that we are hoping that we'll be able to get initiated. And the governor has named a council that I'm a member of that council as well, and we are meeting regularly. We met last week, and then we meet again next week to come up with some policy ideas. So, everything is on the table. We're discussing what all of us can do together to improve access to care to our citizens in North Carolina.
Representative Adcock, are you hearing anything on the Democratic side as far as a push for any sort of state level recovery package to come through, either from the governor's office or from the House?
I would say I have not at this point, but I do think that there's a shared concern across both caucuses to help businesses of all kinds. And being a family nurse practitioner myself for the last 33 years, I would say that most practices are small businesses, and they have been hit hard by a huge demand, a surge of patients who need their help right now. That cannot be put off. And so anything we can do to help providers continue to be there through these stressful times for their patients so that we can keep our community as a whole healthy is something that I think both sides can agree on. And I feel that the governor would be on board as well.
Stu Ann Forrest, are you hearing much from the medical provider community as far as any needs they see related to COVID-19 recovery in the coming months?
Of course, Colin, that's a great question. I've heard more from our members this past year than any other time during my time here at the North Carolina Medical Society. And I first want to say that we are incredibly grateful, much to Representative Adcock's point she was just making, for the support that the General Assembly has given independent providers, particularly those who are working in those rural and vulnerable communities, both in PPE funding as well as independent practice relief. And we have been able to utilize that and distribute it to those really high need areas. And I think we have a lot of success stories of being able to keep those practices afloat. I think one big concern from our members moving forward as it relates to the pandemic is telehealth and how we're going to utilize and reimburse for telehealth in the long term. Many of our practices have made the financial investment, which is significant, in investing in this technology, and they want to be able to ensure that patients can utilize this long term. So I think that is really key of what we're going to do with telehealth and telemedicine moving forward.
Right. Tom Fetzer, any thoughts from particularly the hospital and insurance worlds about needs for COVID-19 relief or legislative action in the months ahead?
Yes, Colin, thank you. And I'm honored to join this august group as the only low-life lobbyist invited to attend, and especially to be with Senator Krawiec and Representative Adcock, two of the most passionate and knowledgeable legislators, not only in North Carolina, but anywhere in the country. So I think COVID will forever change the way we think about our workforce, about the way we think about education, and I think it will forever change healthcare. And I think some of the things we've learned from COVID is that we can be more agile than we have been. And it's also shown us that we can work together. As a result of COVID, you've got insurers, providers, hospitals, provider networks working together to come up with solutions. One of the things that two of my clients have participated in, Blue Cross Blue Shield and Wake Med, have partnered with 6 other major hospital systems to reduce costs and to go to a value-based care system. One of the things that North Carolina could do is relieve some of the restrictions on expanding value-based healthcare approaches to all insurance plans. There currently it's limited as to how far that can be administered. And the other thing I think that's really important is 23 cents of every healthcare dollar is consumed in pharmaceuticals. And we've got to do something about the exploding costs in pharmaceuticals. In just the first half of 2020, there were 4,400 increases in prescription medications by Big Pharma, and only only about 400 cost decreases. So that's 96 cost increases for every one decrease. The profits of pharma companies are outstripping the other 357 non-pharma companies on the S&P 500. And this is just one example. In the United States, our taxpayers support 85% of the cancer research in the world, and yet Americans pay 50 to 100% higher costs for cancer drugs. So we've got pharmaceutical costs are the big cost increase driver in healthcare, and I think we've got to do something to address that.
Tom brought up some interesting points there. If Representative Adcock or Senator Krawiec, if you'd like to respond a little bit there.
May I do that?
Go ahead.
So I was really taken with, all of Tom's remarks are right on target, but I was really taken with the comments about telehealth. I'm going to tell you that this is a disruptive innovation that couldn't be stopped, and I believe the toothpaste is out of the tube with it. Patients have come to expect to be able to get certain healthcare services through telehealth. I want to give a shout out to all of our insurers in the state who stepped up with reimbursement parity for telehealth visits, even for providers like my practice that did not have the entire platform in place to meet all the specs that would have been required pre-COVID. This has been a huge benefit to patients, a huge benefit to providers. There's just no way to overestimate the difference that the ability to provide care this way has provided. And because of that, because of now this greater demand for the use of broadband for not just healthcare, but also education and economic development, it just begs the question of what our state is going to do about expanding rural broadband across the state equally, because we continue to now have an even bigger case for the haves and the have-nots when it comes to internet connection, and we just can't have that. We also can't expect our hospitals, both the larger ones, but particularly the rural ones, to be able to provide robust quality, outcome-based care in their communities using telehealth if they don't have high-speed internet. So that's just something that is critical and top of mind, I think, to all of us. I was very appreciative that he brought that out in his remarks.
Senator Kravik, do you want to add anything on that topic? Go ahead, Dutch. Go ahead, Tom.
If I may, Representative Adcock makes a great point. When the insurers expanded coverage parity to telehealth visits, they saw a doubling. Just in 1 month, from February to March this year, they saw a doubling in telehealth visits. I recently read where Duke Healthcare had 1,000 telehealth visits in 1 day. So this is obviously a new tier of service that the customers are going to demand, and they're increasingly comfortable with. And it can dramatically increase access to healthcare and also drive down costs at the same time. And that is something we should all be celebrating and trying to make more, affordable and profitable and accessible in North Carolina.
Senator Kravik, any thoughts on the topic?
Yes, I'll just add to that. Great points from both of my colleagues there. Tom, the pharmaceutical prices that you were talking about are just staggering. Staggering that we have had these kinds of increases that are driving some of our health costs just unbelievably skyrocketing. And that's a great point that you pointed that out. Absolutely, broadband access. There aren't too many bright lights in this COVID pandemic, but one of them is the exposure of what we really are lacking in North Carolina. That has been a good thing that we are aware of all of these things. And it has driven the telehealth that we've been just sort of nibbling at the edges of for a number of years. And we all of a sudden have had to open up and say, okay, we've got to provide care to these people, and this is how we have to do it during these times of a pandemic. So that was one of the bright lights of it, that we have seen what we can do, but we also see what we have to do going forward, because the broadband issue is a tremendous problem for a lot of North Carolina. Our children are falling so far behind simply because many of them just don't have access to broadband, so they're not able to keep up with their studies. So some great points brought out. Thank you.
Yeah. Sticking with broadband for a second, do you see needs to expand the current GREAT grant program for broadband? Is that working well, or are there other policy and funding tools that the legislature can use to try to make sure that everyone does have that access to broadband?
Well, we're going to continue to look for answers. The GREAT program has been good. The problem is that we have so many rural areas that are very scattered, and even with all of the progress that we've made, there's just not accessibility in these very rural areas where neighbors are miles apart, but we still have children there who need to be able to access the internet. We have patients there who need to be able to access telemedicine. So we have to continue to look for ways to do that. You know, we've done the satellites on the buses. Those have been great. They have helped many areas, but those particularly far rural areas oftentimes can't even get to the site where the satellite broadband access is. So we've still got a lot of work to do. But yeah, the GREAT program has been a wonderful thing, but we've still got a lot of work that we've got to do.
Sue Ann, obviously the doctors and providers have been on the front lines of trying to expand telehealth in recent months. What sort of challenges are you seeing most, and where do you think the legislature could step in and make that easier as this becomes a service that becomes much more common even post-pandemic?
Yeah, the North Carolina Medical Society and the North Carolina Medical Society Foundation have been incredibly supportive of the GREAT program. It's actually been on our legislative priority list for, I think, the past 2 legislative sessions. So this isn't a new topic area for us. What I'm hearing most from our members is not just the impact that it makes on health, but like Senator Kravik and Representative Adcock have mentioned, the impact that it has in the education sector, the business sector, which I would argue does relate to the overall health and well-being of our communities. So no specific examples of areas, but I do think and hope that the legislature will prioritize the grant program and maybe think about some creative and innovative solutions to helping increase that access, particularly in those rural areas. Because again, I think our physician and PA community feels strongly that telehealth has helped them be able to continue to see patients in this pandemic. And I think it's a tool that we should utilize moving forward too.
Shifting gears now to another hot topic, Medicaid expansion. Obviously, expanding Medicaid coverage is going to continue to be a heated and fairly divisive issue between political parties in our state. Senator Krovic, do you see any potential for compromise on this subject, or do you think expansion is going to continue to be something the Senate's likely going to have to oppose?
That has been a very hot topic, very controversial topic for a long time. Right now, we're in the middle of a Medicaid transformation. It's been delayed. My thoughts are that we don't even need to discuss expansion until we get through the transformation. It was supposed to have gone live last October. It didn't happen. It is now scheduled to go live July of 21. And I'm hoping that that's going to happen. I know they're moving forward toward that. But I know at the last minute, last session before it was to go live, at the very last minute, it was delayed. Of course, we've had a lot of problems, as we all know, that we've had to deal with. But I don't think, and I hear people say, well, we can walk and chew gum at the same time. I'm not so sure we can do transformation and expansion at the same time. We certainly don't need to be doing that. So my thoughts are we get through the transition, we see how smoothly that goes. That is going to improve access tremendously, we believe. That was the reason for doing it. That was the reason for planning for it for 5 years. And the department had plenty of time to prepare, knowing that go live date, and yet it still didn't happen. So I don't know how we can even think that we can add. I think the governor's proposal is 600,000 people to the system. We need to prove that we can handle Medicaid transformation without burdening the system too much, and see what kind of improvements we make. I'm convinced it's going to improve a lot of access. Right now, the choice of providers is the emergency room for many of our Medicaid patients. We don't believe that'll be the case when we go into managed care. We think that those PHPs are going to make certain that those Medicaid recipients are getting the care they need without going to the emergency room. They'll be able to see their docs on a regular basis. They'll be in communication with those patients. And I think we're going to see a huge improvement in our access. And for me, I really don't want to talk about Medicaid expansion until we get that done and we do some of the other things that we've been trying to do for so long that are going to improve our access, and then see what we need to do.
So once that process ends up and we get to a successful transformation, do you think that's a topic you'd be willing to revisit?
We can certainly discuss it at the time when we see what's happening in that arena. I just think we need to get through that first, and we need to implement some of these other ideas. For some time, I've been looking at some targeted Medicaid expansion for new mothers, for example, for mothers that are in substance abuse treatment. That if they lose their child, they lose their Medicaid. I'm working on a bill to make certain that she's able to stay in treatment, and we can reunite that family. There's just so many things that we can do in that Medicaid space without, and the only conversation that we've had about Medicaid expansion is to 600,000 people. Only about 200,000 of those are actually people that we consider in the gap. Many of those people that the governor's plan would plan to bring in are people who already have insurance on the exchanges in many cases, with very, very little contribution on their part. So they have access. So we're going to be removing people from the private healthcare market and putting them on Medicaid. That just doesn't make any sense. We'll also be picking up the tabs for some businesses. I just don't think we need to be paying for Walmart employees for their insurance. Walmart offers a plan. The employee has to contribute a little, but like every other employer, it's a shared plan and the employer pays most of it. There's so many things we need to look at without saying we're going to just open it up and expand it to everyone that we think should have it, even though they already have insurance in the private market. That just isn't good policy to me.
Representative Adcock, if you want to respond to that and also give me a sense for whether you see any grounds for compromise in the House, particularly with Representative Lambeth and some of the others who have been a little bit more willing to consider some sort of Medicaid expansion in that chamber.
Thank you, Colin. Thanks for the opportunity to talk about this incredibly important core issue for the General Assembly. I would like to say that my House colleagues on both sides of the aisle have spent a lot of time talking about what to do about the huge number of citizens that do not have access to health insurance. And I believe there is some appetite in the House to do something about this. I hear the arguments about trying not to do two huge projects at one time. I can understand that, except for the fact that our state is in desperate economic and health situation because of the 600,000 or so people who have no access to health insurance. This is an economic drag on our hospitals, particularly our small rural hospitals. The impact on individuals and families who have to delay routine health care, much less health care that could turn out to be life-saving for them, it's just difficult for me to get my hands around not going for everything we need to do. And I'll give you an example. So I'm a family nurse practitioner. If I have a patient who has hypertension and diabetes, it's unethical for me to say, I'll treat your hypertension and not your diabetes, because it's too hard to do both of those things. When in reality, if I only tackle one, you might die of the other. And I feel like that's the situation our state is in. Medicaid transformation is very important, and the timeline for this needs to be adhered to. But I don't think we can wait to meet the healthcare needs and the economic needs of our state by delaying Medicaid expansion once again. And I do believe that we have members of the House who feel very similarly. We may have different ideas about how to get there, but we believe we need to get there. And I look forward to working on this again this session.
We're going to move on in just a minute, but I did want to give Tom and Sue Ann an opportunity to jump in on this, and whether there's any potential you see for helping to broker some kind of compromise on the expansion issue.
Sure, I'd love to take that if that's okay, Colin. I think we have a really great opportunity here in North Carolina to create an innovative solution that is driven by all sides of the aisle here in North Carolina. And I know that the Medical Society is really excited about working on this topic. I think we've already seen some proposals of compromise solution, like healthcare for working families, as well as a bill that Senator Kravick sponsored last cycle on small business healthcare. So I think there's some really creative ways that we can address this problem, but it's going to take some conversations like the one that we're having today to really get moving forward on a solution. But I do know that our members feel strongly, and the data shows that more insurance access and more insurance coverage leads to better health outcomes. So if we can keep patients out of the emergency room and utilizing the emergency room for non-emergency care or care that could have been prevented in a primary care setting, I think we'll get better health outcomes. And that, I think, should be a goal of everybody and something that everybody can get behind.
Tommy, you want to jump in real quickly?
I will, Colin. As in all policies, politics is a driving force. And after a tumultuous election nationally, here in North Carolina, we had remarkable stability. Governor Cooper and Senator Berger and Speaker Moore are still the prime players. And the first thing they have to do is to figure out how to get a budget passed for the first time in 3 years. And I actually think that if Governor Cooper had not held the budget hostage to his particular version of Medicaid expansion, we would have had two budgets, and we would also have had some movement on Medicaid expansion, because I do believe there is some interest in both chambers of finding a way to go forward to expand healthcare without accepting skyrocketing costs. And the Republican resistance is based on their experience in rapidly and exponentially escalating unchecked Medicaid costs in the decades prior to their becoming majority in both chambers in 2011. And so I think they're willing to have a conversation, but somehow we've got to figure out a way to make the cost scenario not become cataclysmic for the people of North Carolina while we're expanding healthcare coverage.
Great. Thanks for that. We're going to give our main panel a quick break for a few minutes and bring them back for some other hot topics in just a moment. But we want to turn our attention real quick to another important topic this year. While 2020 is going to be remembered certainly as the year of COVID, there's also been a renewed interest in racial equity issues. And for hospitals, the two topics do seem to overlap. So next up, we're going to talk to Phyllis Wingate, a retired healthcare executive who served as the Northern Division president for Charlotte-based Atrium Health. She's going to talk to us a little about what hospitals are doing to address disparities in healthcare delivery and outcomes. Phyllis, thanks for joining us. To start off, I wanted to get your thoughts on why racism should be considered a public health issue and how looking at it that way differs from looking at disparities based on poverty levels or any other ways you might break down the data.
Hi, Colin. And as the other panelists have said, I'm happy to be able to join this conversation representing the Hospital Association and the Healthcare Association and its foundation. We've been talking about racism at the Healthcare Association, and what our public health experts have helped us to understand is that to be a public health crisis, you have to meet three criteria. One of those criteria is that the crisis has to impact a large group of people. The second is that it has to threaten the health of that group of people over the long term. And the third is that the solution to the crisis requires large-scale implementation or solutions. So racism meets all three of those criteria. I think when we think about it as individuals, we think about it as our feelings one person to another person. But in the space of public health policy and a public health crisis, we should think about it more as a group and the impact that structural racism and unconscious bias has on a group of individuals. I think it's different from disparities in that, in my mind, disparities is the outcome and racism is the root cause. And so if we want to get at disparities, we have to tackle structural racism.
You've had a very long career in hospitals at a high level. Have you witnessed these issues personally in your years as a hospital executive?
Well, the answer to that would be yes. But sometimes you don't understand things right in the moment or name them in the moment, and you have to look at them in the rear view mirror. So I think I would say, I'll give you a couple of examples of this that I understand better by looking at them in the rear view mirror. The first would be my first job in healthcare was the president of a 104-bed hospital in Richmond, Virginia. This was a new hospital with state-of-the-art equipment. It was located in the east end of Richmond, Virginia, in an underserved area, primarily served minority individuals, and the medical staff was primarily a group of minority physicians, really well trained, all American trained. It was managed by Hospital Corporation of America, one of the largest, probably best run healthcare systems in the country. And Hospital Corporation of America owned a number of other hospitals in Richmond that were located in primarily white suburbs. The issues that I had to deal with in my hospital were very different. The health status of the patients coming to my hospital, coming to the physician offices in our community were very different than my colleagues' hospitals in the white suburbs. And what I learned early on in my career was that even for, say, minority physicians, they had difficulty, even if they were equally trained, getting into healthcare plans. If they were assigned white patients, often those white patients would once they found out they were a minority physician, moved to another practice. So you see the unconscious bias and the structural racism that results from that when you're in a position where you're having to make policy and administrative leadership positions in an organization like that organization. The second example, I would say, I also worked for another organization. This was at the time where the IOM report on disparities was being published, and we were starting a national conversation on that. Being a part of the senior leadership team, I proposed that we do a study on the disparities in cardiac care within our medical group. And the members of the senior leadership team asked, why would you want to do that type of a study? We don't have any disparities in our care to patients. We take care of all patients the same. That's a part of our mission statement. And I share that to say that I truly believe that my colleagues believe that. And it's a great example to me of a misunderstanding of structural racism and unconscious bias by well-meaning individuals. And these individuals sit all across our systems and at the policy level. And I guess the last would be on a personal level. I grew up in rural North Carolina. My father died of a heart attack at 53. He had gone to see a white physician on that Friday, was diagnosed with uncontrolled hypertension. He was sent home. He died on Sunday of a heart attack. And I firmly believe that had he been seen by a minority physician or had he been a white male, that he would have been treated more aggressively for his hypertension. So yes, in my career, I have seen the impact of racism and unconscious bias in many areas.
Why do you think it's important for the NC Healthcare Association to be jumping in and taking a leading role in driving the conversation and action around these issues?
I think the Healthcare Association is probably best positioned because it represents hospitals, all 135 hospitals across North Carolina, and their sponsoring organizations. And the Hospital Association is a non-judgmental convener of many people across the continuum of care, as well as stakeholders who are interested in the health status of North Carolinians. They can convene and bring people together to start these conversations and influence policies that are important to solutions in this area. Also, for a long time, the Healthcare Association has been the collector of data related to hospitals, starting with financial data related to hospitals, but also over the years, including quality data and patient safety data. And they have the infrastructure and the expertise to build a data platform that will help us understand this issue better and understand how we can find solutions to it better. They also have the ability to share best practices across all of these organizations, and they have the ability to influence policy. We have great relationships with many partners throughout the state, the legislative partners, foundations, providers across the continuum. So I don't know of another organization that has as broad a reach, that has as much influence on the multiple stakeholders that are involved with improving the health status of all North Carolina citizens than the Healthcare Association.
Have you seen any best practices so far that could be good examples for healthcare providers addressing this issue? And where do you think more study is needed now, particularly that the Hospital Association is involved?
I think the healthcare organizations are working internally and externally on this issue, and there are some obvious best practices that are emerging. Internally, I think many organizations are setting up population health departments. They're recruiting diversity and inclusion officers. They're educating their workforce and their providers on unconscious bias. Externally, there's a lot of innovation, including healthcare organizations buying real estate and providing no interest loans to individuals in minority communities. There's an example up in Appalachia where the hospital built a walking trail so that people in that community could get to the hospital easier. They're converting or underutilized assets into wellness centers or other types of organizations in rural communities that meet those community needs. So there's a number of examples of best practices, and the Hospital Association is busy trying to make sure that they gather that information on best practices and that they are shared across the state.
Any data you think that still needs to be collected to really get a handle on the issue?
There's lots of data already. I don't think we need to collect any more data to make the case that this is an issue. I do think that data is needed to be able to help us make smart decisions about where to begin this work. It's a lot of work to be done, and I think data is needed to be able to measure the success of our interventions. That data needs to be collected by a neutral party, I think, and it needs to be protected, and it needs to be shared in a way that is instructive to us being able to tell whether the interventions that are being made are going to be successful.
All right. Thanks, Phyllis, for that. Really great insights on a really, really important topic concerning healthcare going forward. Joining back from our final segment of today's event, we'll turn back to our panel. Senator Joyce Krovic, Representative Gail Adcock, Sue Ann Forrest of the NC Medical Society, and lobbyist Tom Fetzer. This segment, I want to get a little bit into some of the nitty-gritty regulatory issues that the legislature is almost certainly going to be grappling with, starting with what's sort of a perennial one, certificate of need. For those who aren't involved in the issue, know it well, are the regulations that sort of determine where healthcare facilities can be built. It's been a perennial topic of the legislature as to whether that should be deregulated and have some more sort of free market approaches to that particular aspect of healthcare expansion. But so far, not much has changed. Senator Krovic, do you plan to pursue changes to the system again this year? I know you've been a key sponsor of that legislation in the past, and what would make you optimistic that that could pass the legislature this time?
I think that we will have some form of reform. I just want to give you an example of a recent issue. One of our rural hospitals that is in trouble. They're getting ready to close because they're financially, they just can't hold on any longer. There was a purchaser wanting to purchase the hospital in a rural community. They could not use the hospital for what, and I don't remember what they wanted to use it for, what their intent was, maybe cancer or something, I can't remember. But because another hospital had a certificate of need in that area, they were not able to do it. That certificate of need, this particular entity had held for years and had never exercised it. We have to have some reform in the certificate of need space. It is outdated. North Carolina is the fourth most regulated state in the country. We regulate 28 services. There are several studies out there that say that would be one of the best ways that we could reduce costs and improve access to healthcare in North Carolina, because we are so restrictive. I think New York, New Jersey, and maybe Hawaii or somewhere. I mean, nobody in our geographical area, even close to us, on the regulations that we have on certificate of need. So I think it's absolutely necessary that we look at some kinds of reform to our certificate of need space in North Carolina. And I think it's going to make a huge difference. And one thing I just want to back up to Colin for just a second, if I may. Sue Ann mentioned the Small Business Health Care Act that I sponsored last session. Thank you for bringing that up, Sue Ann. That is one of the best pieces of legislation that I think we have done in North Carolina in a long time. Huge support for that bill. The business community, the chamber, I don't know anybody who was opposed to it. In the end, there was some opposition at first, but we worked out all the details and it was very, very popular. It was estimated that that bill was going to bring 100,000 people from the uninsured rolls to the insured rolls. That's huge. That is huge. And it's going to reduce costs for all of those small businesses. It was stopped by the Department of Insurance because there is another state where there is a challenge on a lawsuit. I'm going to be advocating to the insurance commissioner that we go ahead and roll that out. We don't know what the court's going to do. It may be years before that decision is made. North Carolina could already be offering low-cost insurance to a lot of employers that they would be able to cover their employees. So I'm going to be advocating very heavily for that as well.
Tom, you represent some of the hospitals on this issue. Do you see any version of certificate of need changes that the hospital community would be able to support? I know there's been a lot of opposition in the past, or is there a case to be made that the status quo is working well and should be kept?
Well, I don't think anybody would say that status quo in any area of healthcare is going to work in the future. But hospitals work under a peculiar set of circumstances. You know, we use the word free market a lot, but hospitals do not work in a free market. They were required by the federal government to admit and stabilize any patient who comes to their door, regardless of their ability to pay. So let's assume for a moment that orthopedic surgeons get a CON to operate a standalone ambulatory surgery center in Raleigh. They can charge less for that operation than the hospital can, because a hospital payer mix is 1/3 private insurance, 1/3 Medicare, Medicaid, and 1/3 no pay at all, which means that 2/3 of the procedures they get reimbursed less than what it actually costs. So the orthopedic surgeons can make more money, and they can charge less for that surgery, but they're not open 24/7. They don't have an emergency room, and they get to pick their payer mix. So if we're going to do this and make it fair for everybody, if you want to reform CON and allow different medical practitioners to open up their own mini hospital, then they have to be required to stay open 24/7. They have to run an emergency department. They have to accept any patient, and they have to accept any patient regardless of their ability to pay. Then and only then are you going to have CON that has a chance of working, because otherwise different little physician groups will just set up practices that will bleed the profitable lines of business from the hospital, and they'll get stuck having to charge the patients who actually come to the hospital even more money to pay for the 2/3 who aren't paying for the full reimbursement cost of the services. So it's a tough one. It's a tough one, but hospitals are willing to be a part of the conversation. But here's the thing. What we know about government is government always works better when it incentivizes outcomes rather than forcing outcomes. And what we've learned from COVID is that insurers and providers and hospitals have developed an unprecedented sense of collaboration and willingness to work with patients for better outcomes. And I think as long as the legislature is willing to include all the players in helping to create the solutions for the future, we'll get to a better place.
Senator Kravick, you want to respond to some of the concerns that Tom raised?
Yes, I love you, Tom.
I love you too, Joyce.
The bill that I sponsored actually did take care of most of the concerns that you just brought up.
I'm aware of that.
We're going to have so many pro bono cases. Basically, they were going to have charitable care. We were requiring that they have so much. Now, 24/7, they don't stay open, but most hospitals are open because of their emergency rooms. They don't necessarily schedule elective surgeries all 24/7. So we may have to talk about that, but I'm looking forward to talking with you about it, as I always look forward to talking with you, but hopefully we'll get some reform on certificate of need that's going to be good for North Carolina.
Anyone else want to jump in on that topic before we move on to the next topic? Hearing none, let's talk medical licensing for a moment. Those issues seem to be another frequent topic of conversation at the legislature, ranging from out-of-state providers being able to serve North Carolinians to what medical providers with which level of medical licensing can provide certain services. Do y'all see any major reforms that could be in the works or could be necessary next year? And we'll start with Representative Adcock on this.
Well, thank you for that. I was hopeful that I would get this question. Absolutely. I think as we are entering an unprecedented time for needs for financial assistance and having less money than we would want to have, we need to look at a couple of things when it comes to regulation. And the first is to decrease barriers to out-of-state licensed professionals who are entering practice in North Carolina. I think we can improve our processes on that. Particularly a subgroup of these people are veterans and the spouses of veterans. If we want to increase the pool of providers in our state, there's a lot we can do in that space. But the other, I think as I'm entering a session that we know where the needs are going to be great and the finances are going to be slimmer than usual, that we need to look at some regulations that currently tie the hands of licensed providers and prevent them from providing the full amount of care that they're educated and certified and trained to do. Particular groups, if you want to, nurse practitioners, physician assistants, certified nurse midwives, pharmacists. I mean, I believe our state needs to deploy our entire workforce to its full extent. And we can do this actually in a budget neutral way, because at a time when people are going to need, we need more money for education. We need to look at broadband. There's so many things we need to spend money for. This is one of those things we can do that will increase our bandwidth for providers and actually be a budget neutral solution.
Senator Kravick, any thoughts on what Representative Adcock just outlined, but the licensing issue as a whole?
This is something she and I agree on completely. Several states have expanded the, you don't even need to expand the scope of practice, just allow providers to practice at their trained level. And we've been talking about our rural areas and how many new providers we need in those areas to take care of the needs of those citizens. Arizona did I guess you'd say a pilot where they allowed nurse practitioners to practice at their full authority. After 5 years, they had reported a 73% increase in providers in rural communities, 73% increase. So there are a lot of things we can do in the licensing arena. We've done a lot of that, as Representative Adcock mentioned, for our military spouses. We've allowed them to be able to move through the system, to have reciprocity, to not have to jump through hoops to get licensed in North Carolina. And there are a lot more things that we can do in that arena. So Representative Adcock and I agree completely on this, and I'm looking forward to working with her on making that happen.
Thank you, Senator. Can I just add to that? I appreciate the great collaborative work we've done on this. And I would just add that this is not a new idea. 23 states in the country and the District of Columbia have passed such legislation, and some as long as 25 years ago. Arizona was one of those. And not a single one that's ever passed this kind of legislation that allows advanced practice nurses, for example, to work within their full licensure has ever gone back and gone back to the old way of doing things. Right. So what they have learned is it serves their citizens well, and that's exactly why North Carolina should do it as well.
Exactly.
Sue Ann, I wanted to get you a chance to jump in on this, since I know there's been some concerns voiced by physicians in the past about unintended consequences with making some major licensing changing. Do you see any sort of concerns that should be considered as this issue comes up?
Sure. Our members really believe that education and training are incredibly important in patient care. And I think we can all rest assured that we want to see the best and the brightest of whatever specialty area that is when our family members are being seen by any particular provider. I do think that a value-driven healthcare system, like we're moving towards in Medicaid transformation and in the private market sector, is going to increase the team-based setting that we think is so important, and utilizing all members of the healthcare team effectively will be incentivized to do that even more so. So I think that's really something important to note. But also the Medical Society and the North Carolina Medical Board are hoping to introduce a interstate medical licensure compact bill that we think may help with some of these areas, particularly for our military spouses who may be moving. There are 30 states that have already signed on to this compact. We think it could also help with telehealth too. We're working closely with our physician specialty counterparts to make sure that they're comfortable and on board with this as a proposed solution. But we think this could be something innovative to help help us in this area and help increase access as well as telemedicine access.
Tommy, you want to have the last word on this topic? Any other thoughts that issue raises for you?
I couldn't think of a thing to add that would be any better than what I've already heard.
All right. We've got in the few minutes we've got left. We've had some audience questions that were submitted to us ahead of the event, and a lot of these are topics that we've actually been able to get to pretty much in depth. But there was one that I wanted to jump back to. I think we mentioned Medicaid transformation a little earlier in the hour, but we had this question from a pediatrician who says it's going to be extremely difficult for physicians to implement the Medicaid transformation change in the middle of the pandemic. Obviously, it changes a lot for their business model and sort of insurance models. This gentleman says, as a busy practicing pediatrician with a large Medicaid patient load, I would hope the General Assembly would consider delaying Medicaid transformation until at least January 1 of 2022. Any chance of that? Senator Kravik, if you want to start.
Medicaid transformation has been delayed a couple of times already. I don't see that happening. I certainly understand what he's saying. It's not going to be easy in the middle of a pandemic, but I don't see delaying it again. We have so many contracts are out there. These providers, based on the go live date that we had before, they were losing millions of dollars every month. They set up the infrastructure. They were ready to go. They made a commitment to North Carolina that they were going to do this, and they were ready. And then when we put on the delay, a lot of these providers were just bleeding for a year now, more than a year. And I don't think we can. I don't think it will be easy for that to be delayed again. It has been delayed a number of times. I understand we are in a pandemic, and I get that, and it's really a difficult time for everyone. But I don't see transformation being delayed again, certainly not at the legislative level.
Representative Adcock, anything you're hearing on the House side or any concerns you may be hearing from the folks over at Health and Human Services about the current deadline, which is coming up on us fast in the middle of this coming summer?
No, I haven't heard anything in specifically. I would say that I know DHHS is committed to Medicaid transformation. They've done everything in their power to hit all the milestones on time, and they believe that this is the right thing for the Medicaid program to transition to, and they will do their best to meet all the deadlines.
Sue Ann, are you hearing similar concerns from other providers, or are a lot having sort of a different perspective on how easy this transition is going to be able to navigate it from the provider perspective?
Yeah, Colin, thanks. I think we all need to be reminded that Medicaid transformation is called Medicaid transformation, right? We are completely changing the way the Medicaid program works. We think for the better long term, again, because we're utilizing more team members, we're moving to a value-driven system, but that comes along with a lot of challenges to our physicians and other healthcare providers within our communities. I do want to brag on our members in particular. North Carolina has one of the highest physician Medicaid participation rates in the country. And I think that's great and that is fantastic. And we want to make sure that we keep that moving forward into this transformation. But that doesn't discredit the fact that we're in a pandemic right now, and it is going to be incredibly challenging, like Senator Kravik mentioned. But I think we will need to move forward so that we can get to those better healthcare outcomes that we believe will come along with moving to the managed care system.
Tom, any concerns you're hearing from some of your clients around this particular topic, and whether there's any changes that might need to be made going into the new year?
Well, I think everybody agrees Medicaid transformation needs to happen, but I think we have to be careful about the amount of change we're asking people to absorb all at once. Even before COVID, there were massive disruptive changes in healthcare delivery. And so insurers, I know Blue Cross Blue Shield has spent $600 million it wasn't planning to on COVID-related responses. And I'm sure the other insurers are in the same boat. Hospitals, in many instances, losing elective surgeries, were losing some of their most profitable lines of business. And physicians and healthcare providers have been hit the hardest. They've had to close down their practices, stop seeing patients. So we've got to be careful that we don't ask these three critical components of our healthcare delivery system to absorb too much change too fast when they've just been hit by a body blow. A life-altering event and a business-altering event in the last 6 to 8 months. So I think I agree with Senator Krovic. It needs to happen. I think the pace of implementation needs to be done in collaboration with the people with whom it is going to affect the most.
All right. Well, I think that's about all the time we have for the Insider's 2021 healthcare policy preview. Been a lot of really important topics we've got to, and you guys have had some really great insights on what we can expect on a whole host of issues going into the new year. So thanks for all of our panelists for their insights into this. And thanks to all of you out there for joining us today. I'm Colin Campbell with the NC Insider, and we hope to talk to you all soon. Stay safe out there, keep your masks on, and have a great rest of your week.